Good morning, and thank you to the program committee for the honor of being asked to give one of the IAES state-of-the-art lectures. I have no relevant disclosures. When you hear the term adrenal cancer, I bet most of you immediately think of adrenocortical cancer, maybe because of its aggressiveness and often poor prognosis. Some of you may have gone on to think about malignant pheochromocytoma, and I bet few really thought about the other primary adrenal malignancies listed here on the right of the screen. We tend to think about ACC most often, but we need to remember there are other primary malignancies of the adrenal gland. Malignancies metastatic to the adrenal are not something we're going to cover today. Since 30 minutes is a short period of time to cover the breadth and depth of all things adrenal cancer, I've chosen to focus on a few specific topics that I think are the most impactful for this audience, recognizing we have both general surgeons and subspecialized endocrine surgeons here at the World Congress of Surgery. Even though we just talked about the multiple different types of primary adrenal malignancies, I'm going to focus on ACC alone and information that's relatively new. I'm going to spend little to no time on general evaluation of adrenal tumors, but I do want to highlight a few things. To quickly remind everyone, comprehensive biochemical and imaging evaluation is necessary, and a selective approach to hormone testing based on signs and symptoms is to be avoided, as 25% of patients with autonomous hormone production have subclinical disease. In those suspected to have ACC, additional intermediaries in the steroid synthesis pathway may be ordered. Something that can be helpful in differentiating benign tumors from ACC, but unfortunately is not nearly as available in the rest of the world as it is in Europe, is analysis of urine steroids. These have been studied for over 20 years, led by Vibke Arlt at the University of Birmingham in England. There are 3 steroids in particular listed here in the bottom right-hand corner that were the original ones identified as most important for identifying ACC. 40 different steroids are usually included in the analysis. In the United States, you can get this testing through the Mayo Clinic lab. Some data on serum steroids was just presented at the International Adrenal Meeting in Boston in May. This work came out of the adrenal group at University of Michigan. And since these are obtained from a simple blood draw, it's more likely that they will be widely utilized. However, it's still under investigation and not clinically available yet. Ultimately, urine and serum steroids, along with other biomarkers and circulating tumor cells and cell-free DNA, hopefully will be able to be utilized not only to assist in diagnosis, but also surveillance for recurrence or progression. A reminder about tissue sampling and also a nod to those who began this wonderful organization. This is a drawing from Norm Thompson, one of our founding members and past president of the IAES and AAES. When we zoom in on this drawing, you can see Norm has illustrated what he thinks is a recurrence of adrenal cancer along the needle track from a biopsy. Biopsy of an adrenal tumor is rarely indicated, as differentiation between benign and malignant tissue of adrenal origin is usually inconclusive, and it can lead to seeding of the needle tract. If considered, it should be discussed in a multidisciplinary fashion prior to pursuing, and if pursued in select situations, never done so until pheochromocytoma has been ruled out to avoid hypertensive crisis. A little bit about updates and guidelines in imaging. In 2023, new guidelines from the European Society of Endocrinology were published regarding management of adrenal incidentalomas. There are significant changes and recommendations for how incidentalomas are assessed by imaging and resulting care, and I urge you to read them. I think many of us struggle with what to do with the patient in their 20s, 30s, 40s, 50s with a benign non-functional nodule. For most adrenal tumors, the recommendation will be no further follow-up. However, the data we have, I don't think is robust enough to know what happens 30 to 50 years down the road. I think we have some work to do rather than burying our heads in the sand and forgetting about them, not just from a cancer standpoint, but also knowing that subclinical autonomous hormone secretion like cortisol and aldosterone have serious consequences on morbidity and mortality, even with very mild disease. This is a summary slide of recommendations according to nodule size and density. And while this table is attempting to package everything into a nice, easy to follow flowchart, I feel the guidelines focus on CT and don't emphasize the important complementary role of other studies which may alter decision making. I say this because some of the messages I see from endocrinologists on social media. I think we as surgeons need to take this a bit further. How do we use different imaging and other diagnostic modalities in a complementary fashion to arrive at a more secure diagnosis? The decision to operate can be relatively easy, but more information is helpful if malignancy is being considered. MRI and PET-CT can be additive in specific ways to inform decision-making. The guidelines state more imaging can be obtained, but don't really provide the different indications for when to do that and how each different modality might help. Let's talk a little bit more about long-term changes in nodules. I'll preface this by stating that we do need to keep in mind that ACC is rare, and so what I'm going to review should be kept with that in mind. We know some ACCs are very slow growing, taking up to 8 or more years to grow and declare themselves. So how do we keep an eye on these things over decades while being cost-effective and not over-treating or over-analyzing? I don't know what the right answer is for this, other than discussing within a multidisciplinary setting to develop a reasonable plan. In some, we'll offer them surgery for a moderate-sized tumor simply to get it over with and avoid decades of hemming and hawing and worry, especially from primary care physicians who may have less understanding of the disease processes. In others, we wait for change or to find a more suitable situation in their lives to address the issue if it needs treated. What happens if it becomes malignant? How do we catch that in time? Will it be spot checks of biomarkers rather than imaging or a combination? Well, let's talk about the adenocarcinoma sequence. It exists for many types of malignancies, but until recently, we had not proven it in ACC. Over the past 2.5 decades, we've seen more than a dozen cases where an adrenal cancer appears to arise from an adenoma. And for those who attended the IAES meeting this spring, I presented a case from a patient I operate on where we now have sequencing from both benign and malignant portions of the tumor to suggest from a molecular standpoint that there is indeed an adenocarcinoma sequence in ACC. This is from the pathology report. To make this even more unique, this was an aldosterone-producing ACC, which is quite rare. There was a clear adenomatous portion within the 3-centimeter mass. The malignant portion contained high-grade areas. There was a difference in expression of aldosterone synthase between the adenomatous portion and the malignant portion, which I'll show you. Immunohistochemistry that was done leads us to remember the important role of the Wnt beta-catenin pathway in IGF-2 and ACC. And now I'll go through the H&E stains. Here you can see the nodule with a fairly normal appearing limb of the adrenal cortex and some medullary tissue, and the adenomatous and malignant portions of the tumor. A high-power view showing mitoses, and a view of the interface between the adenomatous and malignant portions. A little higher power view, and some areas of necrosis. These are the stains for aldosterone synthase, which you can see is strongly positive in the adenomatous portion with reduced expression in the malignant portion. Okay, on to additional studies. I do want to acknowledge Tom Giordano, Toby Else, Antonio Lorario, and the rest of the Michigan Endocrine Oncology Research Group who ran these analyses. 3 different areas from adenomatous and 4 areas from malignant tissue were sampled. Exome sequencing identified a number of shared and distinct areas of mutations. And this diagram shows a sequential acquisition of mutations, some common, some new, as we progress down the diagram in the different areas that came from adenomatous and then malignant tissue, and one from a high-grade area. We also have RNA data, and we're in the middle of reviewing all of that, as there are some unique findings in that too. So we feel this data strongly supports an adenoma to carcinoma transition in ACC. Now, what does this mean? I did hear after I presented this at the IAES that some people were having a little bit of a difficult time making sense of what this means for how we'll follow adrenal nodules. I don't really find the sequence surprising at all, but it doesn't mean I have an answer for how best to follow these nodules over decades. Perhaps the answer lies in intermittent assessment of biomarkers. However, cost and clinical availability of those is prohibitive at this time. All right, let's switch gears and start talking about our favorite topic, surgery. I really like this ad campaign from AT&T from a number of years ago, and this one in particular is spot on for what we all strive for, optimal treatment of every patient. To take a tagline from another ad campaign from Ford back in the 1980s, quality is job one. That is our duty to our patients, the IAES too. We know there is a volume outcome relationship for adrenal surgery, but this data is really dominated by data about adrenal surgery for benign disease. Surgery for adrenal cancer is different. In addition to the usual outcome measures of morbidity and mortality, for cancer cases, we need to be tracking different measures to indicate quality surgery was performed. Capsular disruption, margin status, local and peritoneal recurrence, rather than simply recurrence of nodal or distant disease, which is more likely related to angiolymphatic invasion, tumor grade cortisol production, and other non-surgical factors. In the fall of 2022, the operative standards for adrenal cancer surgery were published. A group of just over 20 surgeons experienced in ACC from endocrine surgery, surgical oncology, and urology, along with a pathologist and endocrinologist, created what are really the first in-depth comprehensive recommendations for the key technical steps of resection for adrenal cancers. This is available through the American College of Surgeons using the QR code on the screen. Before we talk about the critical elements of resection, a minute on thinking about management from a phases of care standpoint, including pre, intra, post-op, and post-discharge phases. What's shown here in this table on the left is an example for those with cortisol excess, not specific to ACC, but from a paper on cortisol excess and JAMA surgery. On the right of the screen, a table from the operative standards, medications to control adrenal hormone excess, which is key in the preoperative preparation of some patients with ACC. And I do think this is important that surgeons be very comfortable with these medications. When considering the need for medication prior to surgery for ACC, there is a balance which must be found between taking time to optimize patients, especially in those with severe cortisol excess, versus getting the operating room to remove the tumor. There are 4 specific items that define the critical elements of resection. These seem obvious on the surface. However, additional details lie within the recommendations and even more within the explanation of the rationale for the recommendations. It's important to read the entire body of work to truly understand all of the nuances. For example, when we say R0 resection without disruption of the tumor capsule, that means more than just shelling out the tumor from the surrounding adipose tissue. This is because of how ACCs spread into the surrounding soft tissue and because part of the pathologic assessment for staging is assessing the adipose tissue. Peritoneal lining and Gerota's fascia serve as an anterior margin if there is no tumor invasion through this. At the IAES meeting this spring in the adrenal lunch session, Thurston Drake quoted something from a paper Jerry Doherty and I wrote a decade ago, and I think this is true. Technique matters, and you've got to get it right the first time. There really aren't do-overs in surgery for adrenal cancer that provide a mechanism for long-term cure. Just because you do an open approach doesn't mean you've done it well, and hopefully these standards will get everyone on the same page. Here's what I mean. The diagram shows inclusion of the entire area of adipose tissue surrounding the adrenal gland rather than simply dissecting along the edge of the gland. In a series we published when I was at the University of Michigan, 25% of patients presumed to be stage 1 or 2 based on preoperative imaging and intraoperative inspection and palpation were found to be stage 3 after pathologic examination due to microscopic invasion of tumor cells into the periadrenal adipose tissue. The picture in the bottom left shows how we do not expose the tumor if possible, and instead stay inferiorly over the kidney to leave adequate soft tissue between the inferior aspect of the gland and what will serve as the inferior margin. A picture after removal of the tumor shows that the posterior aspect of the tumor is completely covered. This is the left side, where we go over to the aorta medially, trying to maintain whatever soft tissue we can medially, as well as inferiorly onto the left renal vein. Think about it in this way, like a tree and its roots, where the tree is the adrenal and the roots are invasive cancer cells. The picture in the top left of the screen shows tumor invading into the surrounding adipose tissue. So don't dissect like this, where you'll end up leaving tumor cells leading to recurrence. Dissect widely around everything. You want to package the tree, roots and all. Another area of the standards concerns multivisceral resection. In particular, the standards focus on how to handle varying degrees of invasion of the superior pole of the kidney, as this is commonly encountered. What we want to avoid is creating a plane that doesn't exist, where in the process the margins are compromised and tumor cells may be spread, leading to local regional recurrence and peritoneal carcinomatosis. And this video illustrates just that. This will loop as we're talking. This is from a left adrenalectomy. We're starting our dissection over the kidney and rolling the tissue superiorly toward the tumor. We can feel from the outside and eventually can see the tumor may be invading the superior kidney. We want to avoid trying to forcibly separate the structures from one another. You could perform a partial nephrectomy to spare the majority of the kidney. However, in this case, there were other reasons for nephrectomy. After removal of the specimen, you can see the broad adherence and immobility of the tumor in relation to the kidney. There was no frank invasion on final pathology, but that's not something we want to assume in the operating room. In some cases, you can dissect beneath the capsule of the kidney and peel the capsule off if there's tumor adherence, but not obvious invasion through the capsule. Our aggressiveness with nephrectomy in some ways relates to our postoperative use of radiation therapy to the tumor bed, which renders the kidney mostly non-functional anyway. There's been data published in the past year that supports several other studies from the past decade and a half that XRT is associated with improved outcomes, but I don't have time to go into that today. As part of the operative standards, literature reviews are performed to answer key questions. Whether to operate in the setting of stage 4 disease at presentation, the debate about operative approach is shown here, and whether to perform prophylactic lymph node dissection were all covered in the operative standards. 2 slides on operative approach because while the language may seem simple, it is nuanced. While an open approach remains the recommended standard approach, there is some latitude in this statement. If a surgeon intends to proceed in a minimally invasive fashion, they must have considerable experience in both minimally invasive adrenalectomy, not translating skills from laparoscopic cholecystectomy, and have considerable experience with ACC, and have acceptable oncologic outcomes, rates of capsular disruption, local and peritoneal recurrence, and they must be able to perform all critical technical elements as described in the standards. This includes examining and feeling for renal hilar lymph nodes and other nodes nearby. Outcomes need to be compared not to the surgeon's other outcomes, but instead to those with the best outcomes. For the thousands of surgeons out there, meeting these requirements to take a minimally invasive approach where ACC is in the differential will be difficult for most. The review of the literature for this key question led to inclusion of a discussion of the limitations of the existing data. Beyond dealing with a rare disease, selection bias, and issues with retrospective data, there are other less obvious limitations which are discussed in the operative standards. Some studies focused on endpoints that are confounded by variables other than surgical technique, heterogeneity in evaluation, inconsistency in performance of critical elements of adrenalectomy, and variation in long-term treatment, including not offering optimal therapy, having other procedures along the way, and so on, all limit the ability to detect any potential impact on surgical technique and outcome. So I will come back to this slide again. We have one shot to get the initial operation right to help this patient survive. My hope is that we all at least start to understand the critical and unique aspects of removing these tumors, which go beyond simply thinking all we need is a negative margin. That obviously isn't all we need to do, or we wouldn't have tumor bed and peritoneal recurrences. To provide some data about adherence to oncologic principles during adrenalectomy for ACC, this is an unpublished study where we reviewed 84 operative reports from patients seen at University of Michigan from institutions around the country, including other major academic centers. Documentation of adherence to all indicators of an oncologically ideal resection on a per-case basis, which there were 8 indicators for each case that were examined, range from 5 to 51%. A significant difference was noted when operations were performed at tertiary referral centers versus those performed at non-tertiary referral centers, and for laparoscopic adrenalectomy versus open adrenalectomy. We must do better. With that said, reporting practices may not accurately reflect the operation performed. Moving on, briefly, the standards discuss prophylactic lymphadenectomy as that is called for in some guidelines. However, after review of the literature, the group ultimately did not recommend this as a necessary step. Doesn't mean you can't do it, but not a necessary step. Likely, we can get similar information that leads to upstaging, risk stratification, and pursuit of adjuvant therapy in the form of peritumoral microangio and lymphatic invasion available on the pathology report. The working group also developed a new classification system for documenting extent of venous tumor thrombus for adrenal cancers. This is based off of that which already exists for renal cell cancer. So let's look one more time at another picture from Norm Thompson. What might we do differently from what is shown in this picture? En-bloc multivisceral resection, including invasion of the cava or intracaval tumor thrombus. We want to avoid cutting across tumors depicted in the lower middle part of the screen. Clamp proximally and distally and extract or resect the vein intact depending on the situation, and close primarily, patch, or graft depending on what's needed. Those microscopic cells at the transected margin can shed into the region while proceeding with the rest of the operation. More information is provided in the operative standards about vena cava replacement, bypass, and liver perfusion. So now that we've completed the operation, how best do we describe what we did, not only for the individual patient record, but also to facilitate quality and later review? Use of synoptic operative reports to aid in continuous improvement of operative techniques will be key for us to make progress. The Adrenal Cancer Synoptic Operative Report, or SOR, is done, and it will be available later this year or in early 2025. It will join the Thyroid Cancer SOR, which is already available. The adrenal cancer SOR is broken down into 3 sections: the EMR, auto-populated information, tumor-specific information, and additional procedure details. On the right is an example of one of the synoptic elements. Now, how well do people know the operative standards for adrenal cancer, and how well have they been disseminated? It's hard when they sit in a textbook and are not widely available. We're doing what we can to overcome that. One of our medical students at Ohio State worked with me and the Cancer Surgery Standards Program group to develop a survey and educational video. This was based off the Tumor Board education series created for gastric cancer. You can use the QR code here on the slide to reach the video on YouTube and do this with your multidisciplinary group, as it is important for those in other specialties to also be aware of this information. So I'll share a few high-level pieces of the data. We had 149 respondents. 64% were aware of the operative standards for adrenal cancer. And surgeons overall responded correctly to only 49% of knowledge questions about the critical elements, and only 25% expected a moderate to significant impact to the operative standards at their institution. Based on the scores from the knowledge component and the data from the operative reports I reviewed earlier, it's clear we have more work to do. Okay, moving on, let's talk about systemic therapy. From the European Society of Endocrinology guidelines, these are the current therapeutic options and an overview of the objective response rates in studies with systemic therapies in ACC. You can tell by the limited amount of green indicating a response to therapy that we are still searching for an effective agent. I think everyone is well aware that specific treatment for ACC begins with mitotane, which is a derivative of DDT, a pesticide that was widely used for about 20 years. These images advertising DDT always amaze me. They sprayed this stuff all over everybody until it became the first chemical banned by the Environmental Protection Agency. Now, you can read more about this in the book from Rachel Carson, pictured here in front of her typewriter and testifying before the United States Congress. Mitotane was introduced in 1960 for adrenal cancer when it was discovered to cause adrenal atrophy and adrenal insufficiency in dogs. For mitotane used in a non-adjuvant setting, there's a response rate of only about 20 to 25%. And this is with a mitotane level between 14 and 20. Mitotane is not well tolerated due to GI side effects, and even if it is tolerated, it is difficult to get most patients to that therapeutic level and maintain it. And remember that if these patients are not producing excess cortisol to any great degree, they do need to be started on hydrocortisone or they will become adrenally insufficient. While there has been an incredible amount of activity over the past 2 decades in terms of looking for new therapeutic options for systemic therapies, first and second line therapy has not really changed, except that second line therapy is sometimes skipped for other options. Mitotane plus EDP remains the first line option. With the use of molecular data, we do find some patients who respond to particular agents in significant ways, but for the most part, we do not find actionable mutations through Foundation 1 and other testing in most patients. Let's talk about adjuvant therapy. Over time, we've been able to understand who may benefit from adjuvant mitotane. This shows data from over 2 decades ago for the use of adjuvant mitotane. This was from centers in Italy and Germany who determined that patients at higher risk for recurrence do benefit from adjuvant mitotane. The ADUVO trial looked at those with a low to intermediate risk of recurrence and determined that adjuvant mitotane was not beneficial. And now we're in the middle of an ongoing trial run out of MD Anderson led by Mohammed Habra, investigating adjuvant EDP with or without mitotane in patients at high risk for recurrence. So currently, these are the indications our group uses to start adjuvant mitotane. Remember that there are multiple labs to obtain while on mitotane, including thyroid function studies and lipids. It's also important to look at drug-to-drug interactions while patients are on mitotane, as there are many, and it's a CYP3A4 inducer. So what else are we looking at? A reminder from the early 2000s of where we started from when we got into molecular analysis for not only mechanistic reasons, but also therapeutic reasons, and the importance of the Wnt beta-catenin pathway and IGF-2 and ACC. The data from the TCGA project for adrenal cancer published in 2016 was an important step in understanding what drives ACC. ACCs in general adhere to one of 3 main clusters. This figure nicely shows how survival is impacted by tumors according to the different clusters. And since then, we've tried to exploit what we've learned to develop and test new therapeutic agents. We went from mitotane alone to this, an explosion in the number of targetable mutations identified. This figure is from Mohammed Habra from a number of years ago, and we could probably add more to it. Moving forward, rational biomarker and molecular-driven approaches will be required to select optimal strategies for systemic therapies. The use of organoids to identify a favorable response to a number of potential agents may eventually become possible to help select the best treatment for an individual patient and their unique tumor. This is a busy slide, but these are all areas of investigation. As you can see, and as I mentioned before, understanding drug-to-drug interactions when many patients will be on mitotane is important. The long half-life and the amount of time it takes to wash out mitotane from the body also needs to be considered when trying to determine response rates and reporting data. Perhaps there was less of a response because they were on mitotane, which rendered the other therapy less effective. A few words on immunotherapy. We have really not seen great success with immunotherapy as we have with other types of malignancies. The reason for this, we believe, is a steroid-rich and immunosuppressive microenvironment of the adrenal gland. In this study, 2 glucocorticoid receptor signature subtypes were identified that also correlated with outcomes. Expression positively correlated with immune cell infiltration. High GR expression and high immune cell infiltration were associated with better survival. Glucocorticoid excess was associated with low immune cell abundance and unfavorable prognosis. This could mean that the GR signature could serve as a prognostic biomarker and may be helpful for prognosis and response to immunotherapy. What about predicting outcomes for ACC? It is well known that physician accuracy in predicting outcomes is quite poor. We've gotten better over time at distinguishing between low and high-risk features using clinical and pathologic data. A score called SGRAS was developed a number of years ago, and now that score has been combined with molecular profiling. This work has been done by Christina Rocchi, who is in Germany with Martin Fasnacht and is now at University of Birmingham in England. In this study, the COMBI score had the best discrimination among 3 other prediction models and was particularly good in identifying patients with extremely favorable clinical outcomes within the first 24 months after initial resection. So what else is coming? Lots of talk across multiple types of malignancies about utilizing circulating tumor cells and cell-free DNA, not only for diagnosis, but also for surveillance. This work again comes from Christina Rocchi. Cell-free DNA is frequently detected in ACC patients. Sequencing of circulating cell-free DNA can be utilized to assess for actionable mutations, and this may represent a promising tool to predict, again, clinical outcome and complement surveillance imaging. MicroRNAs are tissue-specific small non-coding RNA molecules that regulate gene expression by inhibiting mRNA translation or degrading mRNA transcripts and have been implicated in carcinogenesis. They're stable in body fluids within extracellular vesicles shed from tumor cells or in protein complexes and are fairly protected from enzymatic degradation in the circulation. The tables shown are from Stan Sidhu's group. Theoretically, microRNA expression signatures should be able to be used as potential biomarkers for early diagnosis and surveillance for recurrence and progression. While microRNAs can be categorized according to function and role, and we can identify differential expression, they have yet to be translated into clinical use, so we'll have to see what happens in the coming years. To wrap up, ultimately, as we go forward, we need to digest all of this rapidly accumulating data and center ourselves on our why, which is the patient. We've done an incredible amount, particularly over the past 2.5 decades, both in the clinical and basic science realms, and I'm hopeful that we'll see some significant breakthroughs in the next 2 decades. So that we may continue learning and collaborating and making progress, I do want to highlight 2 upcoming meetings of importance, which are the NSAP meeting and the International ACC meeting. With that, I thank you for your time and the honor and privilege of presenting. I look forward to the IAES in Sydney in 2026. I want to say congratulations to Professor Zidenius on his tenure as our president, and congratulations to our incoming president, Janice Pasieka. Thank you.